Welcome to the summertime fun. What we're going to be talking about in the aspect of heat illnesses, dehydration, along with the burns and then drownings. With the aspect, of course, on the heat illnesses side, talk about any of the metabolic concerns. Basically, our metabolism runs best at around 98.6 plus or minus a degree. Looking at anytime we have increase in temperature, we could have potential problems and all that stuff. Our body, if you remember back to last year when we talked about the heat and colds and all that stuff, heat production versus is greater than heat loss. Our body temperature will increase. Heat loss greater than heat production, we have decrease in body temperatures and all that stuff. Ways that we can maintain, because the whole process is the act of balancing heat production with heat loss, production by metabolism, movement, large muscle shivering, and then any of the heat loss, radiation, conduction, convection, evaporation, and respiration, with the major ones being the radiation through the head and all that stuff, and evaporation. We're not going to be talking much on that side. Pretty much going straight into the illnesses just as a sort of reminder, and then how to treat each of the different things. So heat cramps specifically, kind of sort of what do we think about with heat cramps? Exactly. Okay. Well, I'll just wait for you guys to answer. And then heat exhaustion versus CKP stroke and all that stuff. Heat cramps, it's usually due to loss of salts, large muscles, cramp up. And then what do you think is the treatment for this side of things? Uh-huh. Uh-huh. All right. Yep. Cool environment, balanced salt solutions. Don't give them either salt or water alone. And one of the big things that, of course, once we're getting now into the summertime, if you're outside, they say half a liter every half an hour, really to help maintain hydration status and all that stuff. Heat exhaustion, just from the aspect of we have sweating causes increased blood volume concentration, vasodilation, decreased vascular resistance, and then so it's the aspect of the blood pools like in a lake. End results, we have decreased perfusion to the brain, heart, and kidney. When we decrease perfusion, what does the person look like? Pale. Okay. What else? Okay. Diaphoretic. All right. So the typical thing, your pale, cool, clammy, moist skin, signs they look like shock because they technically are in shock. All right. But then from there, they also complain of dizzy, weak, faint, headaches. And headache is usually the first sign. And we talk about dehydration. If someone complains or they're thinking that they're dehydrated, they already are dehydrated. Treatment-wise, pretty much the same thing. ABCs, get them out of the activity, cool environment, supine position. If they can swallow, then of course having a balanced salt solution. Gatorade is actually fairly good. It has a lot of sugar in it, so it's not always the best, so even diluting it down a little bit. And then transport for any loss of consciousness or if the patient worsens. So what's the difference between heat syncope and heat stroke? Mm-hmm. Okay. Yep. So stroke is more damage. Okay. So syncope is just, yep, you're passing out. Usually both of the temperatures are greater than 40. Okay. Syncope, you have the mild overheating. But the big thing is it's really that last piece. Okay. You don't have the cardiovascular collapse. All right. So the body in heat syncope is still able to get off the heat, unlike in the heat stroke. It just can't get rid of the heat. It doesn't know what to do. Its body systems start shutting down and all that stuff. Treatment wise for the heat syncope, IV resuscitation, transport, ABCs, of course. And then getting into the stroke. Temps, yes, greater than 106. I've seen, you're greater than 40 degrees or 104. This is where the body, it can't maintain the heat exchange process. So you start having problems of damage. All the body systems start breaking down. We lose enzymatic processes. We lose the ability of the respiration side, so we're not building or making energy, which in turn is a or a potential problems and all that stuff. All right. In heat strokes, there's the two different types: the classical versus the exertional. As you can probably say, the classical. When you think of a classical heat stroke, what do we think of? What age? Geriatric. Okay. And then the pediatrics. Okay. So that the biennial or by age, bimodal age distribution. So the real young and the real olds. So back in the 1986, the heat wave, they hit Chicago and a whole bunch of geriatric people die and all that stuff. Elderly, chronic medical problems, anyone CHF, obesity, and then alcoholism. Okay. Decreased loss of consciousness is the hallmark for a heat stroke. So anyone, hot temperatures, loss of consciousness, okay, it's heat stroke until proven otherwise, especially in the temperatures of greater than 104 and all that stuff. Cool them down. Anything from treatment wise, the loss of cooling mechanism. So it's that red, dry, tachypnea, tachycardic, weak pulses, and all that stuff. Cool them down, oxygen, anything to get them down to 102. The misting using the fans if you have the fans with the mist to blow. Packing the axilla and neck growing. What's the other places, remember, that you can. Yep. And then remember the palms, the soles, and the cheeks that I talk about all the time with trying to cool them down and all that stuff. Okay. And then of course, what's what's a potential complication or I guess that's a bad question to ask. People with heat stroke, what are they at a higher risk of developing? That's still a bad question. What is the doctor thinking? Okay. Yeah. The in the guidelines. Okay, let's do it this way. In the EMS guidelines, towards the bottom for the advanced for you. Okay. One of the potential problems, complications, is seizures. All right. So take that into consideration that if they're having active seizures, having ALS care and all that. And again, process of mental alteration, heat stroke, and heat syncope. It's really the brain is frying. That's the telltale sign. We're losing memory. We're losing brain cells because, everything is being split apart and all that stuff. All right. Shifting from our heat, going into the dehydration side of it. And dehydration is a huge factor, specifically, from the aspect of your prevention of the heat injuries and illnesses and all that stuff. As you remember, our body is 67% water. We are, by definition, a walking ocean with everything that goes through, everything that needs the heart, blood, and all that stuff. the requirements. All right. As we said before, if you're thirsty, you're already dehydrated. By the time that your body actually processes that you need fluid and you need to take a drink, you're already down 10 to 15% of your total body volume. Definition, dehydration, lose more fluid than you take in. Body doesn't have enough water to maintain its normal functions. Then, of course, if we don't replenish, we can have potential serious problems. Causes of dehydration can be many, anything from vomiting, diarrhea, sweating, exercising. Young children, old adults are at risk specifically for the chronic illnesses. Children, of course, because they're so low to the ground, they get the whole conduction, vection, all that stuff. And of course, their body doesn't maintain temperature and all that stuff that well. Mild dehydration, dry, sticky, sleep, tired, thirst, decreased urine. Okay. For kids, asking about dehydration, how many wet diapers? On average, a child should be between 4 and 6 white diapers a day. 8 hours, or in any 8 hours more urination for older children and teens and all that stuff. Headaches, dizziness, lightheaded are other classic signs. Okay. So at 3 to 5%, we can have drop in body weight, 8 to 10% in performance with dehydration. With the heart, of course, we lose stroke volume and cardiac output. Stroke volume, of course, goes back to the whole preload and ability to circulate. I won't make you guys remember the calculations for cardiac output right now. And then, of course, with muscles, without having water, we are unable to really use oxygen, and we have the electrolyte imbalance, which in turn that leads to our cramping that we talked about earlier and all that stuff. Performance at the percent level versus just the loss of body weight. 1%, 2%. I mean, even when you start getting into 6% of total body loss, you can start having cardiovascular collapse and performance level collapse and all that stuff. So really, from the aspect of just a very little water loss can have significant impact with our potential. Water, it's important. 75% of muscles, composed 75% of the brain, helps with detoxification. It's in the bones, protects the vital organs. We are, again, by essence, we're a walking ocean. All right. So dehydration. Questions on that? In drowning, just by definition, death, suffocation after immersion from some form of liquid, versus near drowning episode where the person initially survives immersion in the liquid. Of course, if you look at the stages of drowning and all that stuff, stage 1, very first 2 minutes, you have the submersion. From that aspect, the patient either has a little bit of aspiration, and then the larynx collapses down, so you have the laryngeal spasm. From there, person swallows water, so either one of two things: the laryngeal spasm stops, and the person aspirates, which goes into a wet drowning, which is 90%, versus the patient continues with the laryngeal spasms, and then they die because of anoxia, from the aspect seizures and then death. So this is going to be our dry drownings, or about 10% of the patients that we potentially will see and all that stuff. Drowning, looking at from the aspect of metabolic, we have anoxia and acidosis, and then the hypercapnia, which is the increase in CO2 levels and all that stuff. There is a differences between freshwater drownings versus saltwater drownings, depending on the electrolyte imbalances usually that stems from the drowning sides. Causes, of course, contaminated foreign material. Drowning in the Maumee River is different from drowning in the YMCA pool. Bacteria, vomitus, chemical irritants, and all that stuff. Hypoxia, from the aspect of occlusion of the airways. There's the changes into the surfactant. So once you get a whole bunch of extra fluid, it starts actually shifting, or not just the fluid, some of the chemicals break down. You start destroying the type 1, type 2 alveolar cells, which in turn, that's the whole thing that look at the surfactant production. Bronchospasms, right to left shunting, because now we're having an area that's no longer being aerated, so the body will stop sending blood to a specific area, which will increase the potential for the hypoxia and dead space. Other things that we know that causes drownings cause cardiac arrest, the hypoxic encephalopathy, renal failure, and then lack of oxygen can cause cerebral edema, which is bad. The dry lung versus the wet lung. Predominantly, we're going to talk about the wet lung because that is the majority of the cases that we see, 85 to 90%, versus the 10 to 15% with the dry lung. And again, the dry lung, you have the laryngeal spasm when they take in that initial shock, water, crap, and everything stays collapsed down, versus collapsed down and then relaxes, the larynx relaxes, and then they take in the water. So in the fresh water, basically, we got good water coming in. Going back to high school biology, when you have a whole bunch of fresh water inside on one side, and then you have concentrated, salt and all on one side. You have a membrane that can pass through. What happens? Exactly. So you have the diffusion across the gradients. All right. So from there, the tap water gets into the lung, or the fresh water gets into the lung. It crosses over, and you have the diffusion into the lungs. Hemodilution occurs. We have decrease in the ability of the oxygen then to carry, the ability of the red blood cells to carry oxygen. You can even blow the red blood cells apart, and that's the other aspect too of the alveoli collapse and all that stuff. Red blood cells swell. We have ruptures, release of intercellular contents. Potassium gets into the bloodstream. Elevated potassium levels in the blood causes what? The term's hyperkalemia. Real high levels of potassium in the bloodstream does what? So your dialysis patients that miss dialysis for many days, their potassium level goes up. What happens to them? Yeah, it scripts the heart. They die. They go into cardiac arrest. All right. And then from there, the release of the hemoglobin into the blood will cause the rhabdomyolysis, or that's actually the breakdown of the muscle. The myoglobin and the hemoglobin destroys the kidneys, which in turn, that's the cause of the renal failure. Salt lung, we swallow some salt water. Now we have a higher concentration of salt in the lung. Where does the fluid go? Goes from the bloodstream into the lungs. When we get more fluid in the lungs, what happens to them? They drown. Okay? Yep, that's how they develop the pulmonary edema and all that stuff, and they suffocate and drown on their own secretions. Pulmonary injury, hypoxia, atelectasis, and any of the bad bacteria or impurities that can get in there, which can cause further, lung and tissue damage and all that stuff. Immersion versus submersion. So this is always a hotbed topic, from the aspect of, was it an immersion injury versus a submersion injury? From the aspect, with immersion, person drops, hits the water, goes under, they drown. Versus the submersion, they get in, they kind of sort of cool down, and then they drown. The outcome, of course, is different. So if you can cool the body down first and then drown, they actually do better. Versus the ones that get submerged in and then drowned, they don't do well because their bodies are metabolic processes is still ramped up, but they don't get the oxygen. That's how they actually, they succumb to the anoxic brain injuries and all that stuff. So successful resuscitation, of course, is complete recovery if you can cool them down first and then drown versus the cool and then drown. Cold water, cold stress, of course, does prevent the cardiovascular response. And then from there, you do have a gasp reflex. So we hit cold water, our body does what? Okay. And that's how you kind of sort of also prevents, or that will activate some of the laryngeal spasms and all that stuff. And I'm misspelling. Cerebral blood flow decreases 6 to 7% per 1 degree, Celsius drop, which again is important from the aspect of protecting the brain and decreasing all the metabolic demands and needs and all that stuff. And the near drowning concerns, of course, don't attempt to rescue without proper training. If you remember from I don't know if you guys were in Boy Scouts, reach the row, go with assistance. Okay, so take your towel, take your branch, your stick, and all that stuff. Considering your your diving accidents, swimming pools, and all that stuff, neck injuries if you don't know. Resuscitation, of course, from the aspect. If you need to BVM, BVM. If you have to have an ALS provider intubate, have an ALS provider intubate. If they're awake and it was a near drowning, something like that. CPAP, which is always a huge potential help and benefit. No one's dead until they are. Yep. Transport all drowning, near drownings, regardless of how they look. Again, going back into the EMS guidelines that I like to talk about, that 4 to 6 hour time frame when you get into the secondary drowning, and it's all based upon the pulmonary edema, or the instead of secondary, the term is now the post-immersion syndrome, where they swallow, ingest, and it's usually more kids are more prone to this. Your 2, 3, 4 year olds, they're at the different resorts. They take in a little bit of water, and then they have you guys come and look at them. They look great, no problem, but then they develop a pneumonia a couple hours later. Difficulty breathing, they complain of chest pain, they're they potentially lethargic. They're lethargic because they're anoxic. They're not getting the oxygen and all that stuff that they need. And then they have mood or behavior changes. Well, I'd have a mood and behavior change if I was sick. All right. On to the home stretch. We'll get through the burns just as a reminder of stuff, and then we'll be done for the day. And you can go home and sleep and eat some more Timbits. Yes. Not more than just another soft tissue injuries. All right. Just on the anatomy side of it, just remember that the skin is the largest body organ. It has a whole bunch of different functions: sensation protection, temperature regulation, which again is important, what we've talked about over the past couple of things. And then the fluid retention for, again, the inside the lungs. I mean, a lot of that is, by definition, skin. So it has a huge factor in overwhelming. Different layers: epidermis, dermis, subcutaneous. Epidermis is the dry skin, and that has many different layers. The dermis, of course, is the main. That's where all the hair follicles and the nerve endings are. Okay. And then the subcutaneous, which is those three things will again play factors into what the type of burns and all that stuff. Dermis, elective or elastic tissue, specialized structures are down there, blood vessels, sweat glands, sebaceous oil, hair follicles, and all that stuff. Versus the subcu and the muscles. That's our fat protective layer movement, which is critical based upon the depth of the burn that we'll talk about. So major concerns from the aspect is we have potential loss of fluids, our inability to maintain body temperature, and then an infection. That's what the skin, those are the major things that the skin do. Okay, they really keep infections out and all that stuff. Burn severity is based upon the depth, the extent, the location, how long, patient's age, associated factors, and all that stuff. So with the depth of burn, we don't really know. It can be several days before we actually know the depth of the burn and all that stuff, or the degree of the burn. And usually, what they always say, in doubt, overestimate. Okay, so what's some easy ways to estimate burn depths and all that stuff, or burn degrees? Uh-huh. Rules of 9 is one way. What's the other? What's another way? Yeah. Okay. Yep. The palmar surface and all that stuff. All right. Superficial, first degree, usually just the epidermis, red, painful, tender, blanches under pressure. They usually don't have blistering with the first degrees. Okay. Yes, some people say they can have, some people say they don't. But usually once you get into the second degree, once you get into the blistering, that's more into the second degree categories and all that stuff. Heals approximately 7 to 10 days, then they have a nice, golden tan the rest of the summer and all that stuff. Okay. Second degree partial thickness goes into the from the epidermis into the dermis. Salmon pink skin, moist, shiny, painful. Blisters may or may not be present. Heals 7 to 21 days. And again, a lot of it is the blistering side for the classification for that. Burns that blisters are second degree, but not all second degree burns do have blisters. All right. If it gets into the dermal layer, or even under the dermal layer, they don't always have the blister and all that stuff. So a couple pictures here, some bad second degrees of the hand, and then of course the arm and all that stuff. Child face, all that stuff, risk, and then something got splashed onto the kid's chest, arm, and going from that aspect. Or actually, it's more of an adult. That's not a kid on the left. Right. Full thickness goes through the epidermis, dry, pearly, charred. Okay, may bleed, may not. Okay, why is it painless? Okay, nerves are gone, and they usually require some form of skin grafting and all that stuff. All right, so again, depending on, not so much on the left, you could say, yeah, the little bit on the chest and all that stuff, 2, maybe 3 and all that stuff. Definitely though on the right, okay, with the black hands and the X scars and all that stuff. Shoulder, face, and different regions and all that stuff. All right. So rules of 9, 18 for the chest, 18 for the back, front of the leg, 9, 9, heads 9, arms 4.5, so a total of 9 per arm. And then, of course, genitalia get 1. Kids have a bigger head, smaller body, so their head gets a little bit equivalent-wise for the surface and all that stuff. Specifically, more even into the infants, where the infants, they get 18 and arms 9, minimal with the chest and all that stuff. Or the other aspect what you guys talked about, the palmar surface area. It's not your palm, it's their palm. Okay. Critical burns from the aspect versus a moderate versus a minor. Any full thickness, anything involving hands, face, genitalia. Full thickness greater than 10%. Partial thickness covering more than 30%. Or anything that is respiratory injuries. Where should these patients go to? V's. Why V's? Okay. So any burn center is ideally where the critical burns or even moderate burns should ultimately get to a burn center. Anything that has fractures, and then young and old patients, of course, take into considerations for comorbidities and all that stuff. Moderate, 2 to 10 on the full thickness. Of course, anything, hands, feet, genitalia, upper airway. Partial thickness, 15 to 30%. And then superficial burns greater than 50% of the total body. That's a definition of a moderate burn. And then the minor burns, full thickness less than 2, partial thickness less than 15, or superficial, less than 50% is a minor burn, or definition-wise. Associated factors: age, greater than 5, less than 55, and then location. Circumferential is what? Okay. Anything circumferential, chest, eyes, extremities, and all that stuff. Never a good day. All right. So initial assessment, scene safe BSI, mechanism, number of patients, do you need additional resources? All right. So what's the first thing that we want to do after the scene is safe? What? Scene safe, BSI, all that stuff. So you get to the patient, what's the first thing that you want to do for the patient? Before anything? Okay, before that? Scene safe, okay? Make sure that we stop the burning process. What? Minor details. All right. So, have them stop, drop, roll, whatever. Okay. If it's a chemical burn, get them out of their clothes, whatever from that aspect. And go from there. And then from there, then we can do all the rest of our ABCs, assess breathing, start them on oxygen if you need to, assist with ventilations, for any signs of respiratory distress. Always, again, remember taking the consideration of carbon monoxide and or cyanide. If we have the altered or unconscious patient from a house fire, okay, it's not so much the carbon monoxide that we have to worry about, it's the cyanide. And I know that Lucas County is now or will start carrying the cyano kits. Be a red medication. So if you see that potentially, helping out with house fires, that's potentially there. Circulation, signs and symptoms, early shock. Does it from the burn? It's usually from other problems associated. It takes several days potentially for the volume to expand and the person to go into the shock problems. History, how long, type of burn, closed space, loss of consciousness, any allergies, medications, all the typical sample history that you guys take. Rapid exam, estimate, okay, trying to kind of sort of figure out what is not. Remove any constricting bands. If you need to, watches, don't forget about watches, rings on their hands, someone that has a belt, torso, all that stuff. If they're wearing the chains around their neck, depending and going from there. Treat the burn wound. Nose creams, no ointments. Cool them down. Misting, okay. Don't dump. Okay. You don't want to saturate them down, because once you saturate them, what happens to their body temperature? Okay, so they become hypothermic, which is bad. Okay, if you're going to prolong transport, make sure from the aspect of, if you're going to use the wet dressings, keeping the dressings moist so it doesn't dry and stick to the skin and have problems with that. Partial thickness cover, dry dressings or burn sheets and all that stuff. Pediatrics, think about thin skin, large surface, poor immune, small airways. And then from the other aspect, the abuse. In the other slide presentation I have, if they have that, what is the typical immersion burn for a kid? So you have the little baby or toddler, okay. And what's the difference between if it's they kind of sort of did it themselves versus it's an abuse thing? So if I take a kid and I throw them in hot water, what are they going to do? They're gonna scream. Okay. How do they fold their legs and all that stuff? What do they try to do? Yeah. So they pull their legs. They'll pull up, try to push away. So the emerging or potential abuse things, you'll see just the burn on the butt. You'll have the creases behind the knees and all that stuff. So that's the typical burn pattern for potential abuse and all that stuff. Critical thickness, again, greater than 20%. Burning hands, feet, airway. Moderate burns for kids, partial thickness 10 to 20%. And the minor burns less than 10%. Geriatrics, again, the whole aspect, pulmonary, peripheral problems, cardiovascular reserve. They might not have the fluid if it's a bad, if they're a 56%, total body surface area, they might not be able to have problems, or they might not be able to have the reserve that they need. And again, it's not so much the fluid. The burn itself will increase the heart rate, which will in turn cause that's where they lose their cardiac reserve. Mortality, body surface area, age plus percent body surface. So if you have a 90-year-old with 50% body surface area, that's 140%, mortality. Not good. Things to take into consideration, of course, hypoxia, your carbon monoxide, your upper airways, lower airways. So flashover burns, it's not so much, you guys in the fire side, it's not the fire itself, it's usually the smoke and the inhalation problems. All right? That's why you guys should even, while you're doing your overhauling, wearing your SCBAs and all that stuff. CO poisoning, color odorless, binds 200 times stronger to hemoglobin than oxygen. It can cause a lot of problems. Roaring in the ears. I've never heard of that one before. And then exposures. They do make your CO monitors, and I think your guys' new life packs will have the CO monitoring capabilities. Upper airways, true thermal burns, look at the face, singed hair, eyebrows, nose, look in the back of the throat. Do you see soot or anything like that? If you do, then that, of course, is that's a huge concern. The burn is going to cause the swelling, which will cause edema and all that stuff, which will, collapse the airway and they can't breathe. Chemical injuries usually is the cause, so something gets down into the lungs. It damages the alveoli, all the lung cells. They start again, the body wants to get rid of it. It starts producing all the chemicals, irritants, fluid, and then from there, a person has tachypnea, cough, rales, and then the carbonaceous sputum. Chemical burns, just some aspect of damaged skin absorption, and then take into consideration, is this a hazmat, and then what type of chemical and all that stuff. Management depends really on what the chemical is. We all have our iPhones with our hazmat apps on it. Most dry chemicals can be brushed away. Not everything likes water. If it is in the eye with the chemical, of course, really think about the aspect of flushing. Prevent your eye exposure, or prevention, of course, is with gloves and eye exposures and all that stuff. Remove the chemical, brush the powder, remove the contaminated products, flush the area if the chemical likes and is okay with water, and then transport. Things to the face, really flush. Keep flushing, ideally, until you get these patients. If you're transporting, it's a 15-20 minute transport time. You should be flushing for 15 to 20 minutes. On electrical, okay, it's not so much the voltage, it's the current. So take into consideration, is AC or DC, the width of the current, types of tissues exposed with resistance and all that stuff. On electrical burns, is it a non-conductive injuries, arc burns, ignitions of clothing versus a conductive. looking at your entrance and exit wounds. Okay, so some traditional exit entrances. I've seen it bad enough where it's from the hand and it blows all the way through. They have an exit wound in the foot, and then from there they've had charred, all the way through the body and all that stuff. Other complications: cardiac arrest, respiratory arrest, spinal fractures, long bones, internal organ damages, and all that. Uh-huh. Yeah, exactly. Make sure everything's on the burn management, ABCs, burn, wound management, and then transport, and if necessary, CPR. Just from the aspect of your ALS indicators for the burn side, any airway involvement, hoarseness, soot in the mouth, partial thickness, full thickness, greater than 20%, and then pain if they need to do pain control.